Welcome to the University of Detroit Mercy. I'm Katie Snyder, Interim Dean of the College of Engineering and Science here at Detroit Mercy. I want to welcome all the Build students here and any guests that we have. Yay for Build students. We're just so grateful that Dr. Brawley could take time out of his crazy busy schedule to come talk to us and talk to you guys. I know that there's a lot you guys can learn from him, and he's really such a role model for all of us. And the fact that he grew up here and went to U of D High, it just is so exciting, and I'm so proud. My husband graduated from U of D High. My father-in-law graduated from U of D High. So I have a lot of connection with the high school, and it's really exciting to see someone graduating from there that has just done so much to help the struggle against cancer. So I'm not going to spend a lot of time talking. I just wanted to welcome you, and I'm going to have Tamia Waller, one of our Build students from Detroit Mercy, come up and introduce Dr. Brawley. Thank you.
Good morning, ladies and gentlemen. I am so pleased to be here with you all today. It is both an honor and a privilege to be able to introduce you to a role model of note, a man of distinction and leadership, Dr. Otis Brawley. Dr. Brawley is a physician, oncologist, researcher, author, and healthcare reform advocate who is currently the Chief Medical and Scientific Officer and Executive Vice President of the American Cancer Society, the largest nonprofit health-oriented charity in the U.S. Dr. Brawley attended school at the University of Detroit Jesuit High School, where he volunteered at a lab in the Detroit Area Veterans Administration Hospital. Dr. Brawley attended the Pritzker School of Medicine at the University of Chicago and received his MD in 1985. He went on to intern at the University Hospital of Cleveland, where he completed his residency in 1988 and became board certified as a specialist in internal medicine. Brawley completed a fellowship at the National Cancer Institute in 1990 and became board certified in medical oncology in 1993. From 2001 to 2007, Dr. Brawley served as the medical director of the Georgia Cancer Center for Excellence at the Grady Memorial Hospital in Atlanta. In 2006, he received the U.S. Public Health Service Crisis Response Service Award and the U.S. Public Health Service Distinguished Service Commendation for his work in New Orleans after Hurricane Katrina. Brawley has published numerous scientific articles and, as an author, wrote How We Do Harm, A Doctor Breaks Ranks About Being Sick in America. His research and publications have questioned the effectiveness of various prostate and breast cancer screenings and treatments. He has also studied the various factors causing health care disparity and has served in editorial roles for numerous medical journals. Dr. Brawley has a world-class understanding of the medical field and a limitless appreciation of what it takes to truly make research in cancer and radical disparities continue down a path of progress. He has a mindset that expands beyond his time and enough strength and grit to inspire a nation. Without further ado, it is my pleasure to welcome Dr. Otis Brawley.
Thank you. Thank you for writing that. That was very kind of you. I want to say it's wonderful to be here. I want to thank Dr. Jacob Kagi for arranging all of this. I want to thank the students who I spent a little time with earlier this morning. I had fun. I don't know if you guys did. I want to talk to you a little bit over the next 50 minutes or so about cancer control and what I do. I'm a medical oncologist and epidemiologist, and I have the privilege of working both for the American Cancer Society and Emory University. And I have a gig at Turner Broadcasting. I do some medical consulting for Cable News Network. How many of you guys know Sanjay Gupta? Yeah. Yeah, CNN employs me because it makes Sanjay look really good. They put the two of us on TV, and the contrast between the two of us makes him look even prettier. And then I do some consulting for the government, and I always encourage you, whenever you hear scientific talk, find out where people get their money from. I also wrote a best-selling book that did pretty well, and thank you guys for the guys in the red shirts who actually read it and asked me some questions about it today. I'm going to talk to you about what is cancer, where we have come from, and where we're going. First, as an epidemiologist, and I was telling the folks earlier today, keep an open mind as you go through college about all the various things that you could possibly do. I didn't know what an epidemiologist was when I was a first year in college, and some people would actually say I didn't know what an epidemiologist was now, but anyway, I are one now, but I can even spell it. But anyway, in any event, in 1900, for every 100,000 Americans, 64 died from cancer. In 1991, for every 100,000 Americans, 215 died from cancer. In 2013, last year for which we have data, we're at about 163. That's a 25% decline over about 23, 24 years. So the actual mortality rate, death rate, risk of death from cancer, whichever you want to use, has gone down by 25% over the last 25 years. And that's generally a good thing. This is death rates from 1991, 1990 or so by race. And these are blacks in blue, whites in red, Native Americans in green, Hispanics in purple, and Asian Pacific Islanders in blue. You can see everybody has gone down except for Native Americans and Alaskan Natives. I would be cautious in telling you that race is a socio-political concept in the United States defined every 2 years before the U.S. Census. Race is not a biological categorization. I mention that because we so frequently try to make race into biology in the United States when we talk about disparities in health. My best example on how race is a socio-political categorization is most people do not realize that in the 1970 census, Barack Obama was white, and in the 1980 census, he was black. In the 1970 census, the definitions were you should describe yourself as the race that your mother considers herself to be. In 1980, you were told to describe yourself as the race that you consider yourself to be. I'm saying you consider yourself to be. Most of the audience was not alive in 1980. But in any event, people change races. If you know someone from India, they have been considered 3 different races in the United States over the last 60 years. So race is a socio-political concept. It has nothing to do with biology. Now, brief history of cancer. This is something that was found on the wall of a cave in Egypt, and it's from about 2,000 years before Christ. And it is, when translated from Sanskrit, it is the first mention of cancer that we have in written language. And it says it is a disease for which there's no treatment and is universally fatal. And this goes back actually 1600 BC. Cancer was a rare disease throughout history. Especially in the 18th and 19th century, we started picking up that it existed and writing about it more. Percival Pott was a British surgeon. He identified the relationship between chimney sweeps and a toxin found in chimney soot that caused cancer of the scrotal sac. This was the first person to actually associate cancer with a cause. Now, what is cancer? Cancer is uncontrolled cell growth. It is undergoing mitosis, or one cell becoming two becoming four, and it is uncontrolled. It was first defined for us by the pathologist Rudolf Virchow, who was a German pathologist. He and his students at the University of Berlin did a series of autopsies in the 1840s, 50s, and 60s. And actually in 1853, he published a book talking about these autopsies, and he's the first person to actually do a biopsy. He worked out the technology in which you cut a tumor very thin, place it on a glass slide, stain it first with carmine, and later on his friend Dr. Bayer of the aspirin introduced him to H&E staining, and this is an H&E stain of an adenocarcinoma. This is what cancer looks like under the microscope, and Dr. Virchow did the first biopsies. He cut the tumor very thin, put it on a glass slide, stained it, and looked at it under a microscope, and this is what you see. And if a pathologist, doctor who looks at things under microscopes, sees this, they immediately know that this is an adenocarcinoma. In this case, this is a breast cancer. This is what breast cancer looks like. And in 1853, they did these autopsies. The disease had spread throughout the woman's body. You could see it in her liver, you could see it in her lung. It actually looks kind of whitish and fibrous when you look at it at the autopsy. And then he took that white fibrous tissue, cut it, put it on a slide, stained it, and saw this. Now this is a cell undergoing mitosis. For those of you who have done biology, you know that this is prophase, metaphase, anaphase, and telophase. For those of us who are in our 50s, I stayed up all night memorizing that. Mitosis is one cell becoming two, two becoming four, four becoming eight, eight becoming 16, 32, 64, and I can actually keep going for a while. Uncontrolled mitosis is when it just doesn't stop. If I cut myself, my skin cells start undergoing mitosis. We call that healing. When it is completely healed, a signal goes out amongst the cells. Okay, we're going to stop mitoting. Cancer doesn't have that signal to stop dividing, and it just keeps growing on and on and on. So again, cancer is uncontrolled cell growth or uncontrolled mitosis. The thing about cancer is not only do the cells continue growing or continuing mitoting, but some of the cells can actually break off from the bundle, which we call a tumor, and spread elsewhere. We call that metastasizing. And it's indeed the metastasis that usually causes death. This is a bone scan. You can see the outline of this individual. This is a woman with breast cancer. You can see the outline of her ribs and legs and so forth. All the dark spots here, with the exception of in the pelvis here, all these dark spots are metastases or spread to bone of her breast cancer. The collection here in the pelvis is actually the dye that we use that goes and lights up at the osteoblasts, the cells that are overexcited in her skeleton because they're right next to metastases. That dye accumulates in the bladder, so you can see she has a full bladder of urine that has the radiologic dye in it that we inject for a bone scan. Now, cancer has been a significant public health problem over the last 100 years or so. It was really well defined in the 1850s by Virchow, but again, it was rare in the 1700s and 1800s, and there's been increasing rates in the 1900s or in the 20th century, even when you consider the aging of the population. Cancer today is a disease where the median age at diagnosis is 64. Over half of all people who are diagnosed are over the age of 64. And keep in mind, life expectancy in the United States, for example, in 1900 was somewhere around 58. Life expectancy today is in the 80s. It's actually gone up well over 20 years over the 20th century. Reasons why I showed you the death rate went up throughout the 1900s and peaked in 1991. Suspected reasons, people knew this was happening, just couldn't figure out why. First thing they thought was maybe it's industrial pollution. Then they sort of discounted that, by the way, maybe it is some industrial pollution. Then they thought, you know, we got this new thing called cars. We didn't have cars until about 1903, 1905. And when we started building cars, we started putting blacktop on roads. roads when we had horses and buggies were all dirt. Now we got all these paved roads with tar and blacktop. Maybe that's what's causing all of this cancer. And some people thought maybe it was the chemicals used in World War I. People just couldn't figure out why the increase in cancer. They actually knew the most common cancer seemed to be, the one that was really growing fast seemed to be lung cancer. That's actually an important point. In 1920, the most common cancer in the United States was gastric cancer. The most common cancer in women in 1930 was cervical cancer. By 1940, it had become lung cancer. Lung cancer went from being a disease you never saw in the 1890s to a disease that you started seeing in the 19-teens and 20s and really became very common in the 1940s. Why? Well, it turns out that some German epidemiologists in the 1920s and 1930s figured out that maybe tobacco was the cause. Fritz Lickert in Dresden in 1929, and Franz Hermann Muller in Cologne in 29 and 39, actually published papers that actually were what we would now call case control studies, epidemiologic studies implicating tobacco smoking, cigarette smoking as the cause of cancer. This work was actually lost to us in the United States and the rest of Western Europe because of the rise of the Third Reich and World War II. Some work that was widely published, Alton Ochsner and Michael DeBakey. If you've ever traveled to New Orleans, you know about the Ochsner Clinic. That's Alton Ochsner. Michael DeBakey, to those of us who have a little gray hair, was a very famous heart surgeon. Well, when Michael DeBakey was a medical student, this shows that you guys who are in college now, this shows that you can actually achieve greatness when you're 20 and 21 years old. Michael DeBakey did a study in 1941 that actually associated cigarette smoking with lung cancer. And it turns out it was one of the first 3 studies in all of medical literature to say that smoking causes lung cancer. Then along came these 2 gentlemen, Sir Austin Bradford Hill. He later became Sir Austin Bradford Hill, and Sir Richard Dahl, who did a series of studies of smoking and carcinoma of the lung and published them in 1950. They looked at 1,357 lung cancer patients, and they age and gender matched them to 1,357 people that they just found from the census rolls. And they found that lung cancer patients were more likely to smoke compared to people who didn't have lung cancer who were of the same age and same gender. Ernst Wender and Everts Graham at Washington University in St. Louis looked at 605 men with lung cancer, and they compared them to age-matched controls, and they too said, gee, lung cancer patients are more likely to smoke. Doctors Daniel Horn and Kyler Hammond, seen here, worked for the American Cancer Society. Kyler Hammond actually had my job back in the mid-1950s. They looked at a group of 205,000 white men in the United States, followed them over a period of time, over a period of almost 10 years, and said, gee, all the ones who died smoked cigarettes. Dahl and Hill came back and looked at over 40,000 British male physicians and found the exact same thing. All the ones who died of lung cancer seemed to smoke cigarettes. And this became the beginning of a buildup of literature that suggested that cigarette smoking caused lung cancer. And in 1964, Luther Terry, who was then Surgeon General for Lyndon Johnson, published this book on smoking and health. And this is the actual book from 1964 on which the little thing on the side of cigarette packages, hopefully many of you have never even seen this, but on the side of cigarette packages it says, Surgeon General's warning, cigarettes cause cancer. And this is the basis for it, Luther Terry's Surgeon General's report of 1964. Today, we've had a number of Surgeon General's reports on smoking and health, and we have now linked cigarette smoking to at least 17 cancers. The first was lung cancer, the second was head and neck cancer, and then esophageal cancer, even bladder cancer, some leukemias, kidney cancer, pancreas, stomach, so forth. And it is widely considered that cigarette smoking is the leading cause of cancer in not just the United States, but the world. By the way, cigarette smoking causes more deaths from cardiovascular disease than from cancer, although it's going to kill about 350,000 Americans from cancer this year. This is the good news. In 1955, 55% of American males smoked cigarettes. Today, among adult males, it's about 20%. In 1965, 35% of adult women smoked cigarettes. Today, it's around 16%. Varies dramatically by state. In West Virginia, Kentucky, Tennessee, Mississippi, and Arkansas, smoking rates are close to 30% of adults. Close. Smoking rates, at least smoking rates for cigarettes, are at about 10% in California and Utah. At least for cigarettes. We can clearly lower the smoking rate, and we can clearly lower the smoking rate and prevent a bunch of deaths. Now, I will point out that people, that decline in death rate that I showed you from 1991 onward, much of that decline is due to people who stopped smoking in the 1960s and 1970s. People who either stopped smoking or didn't start smoking at that time did not die in the 1990s and beyond. So there's a huge long lead time, and people who we stop smoking now will prevent them from dying in 20, 30 years. How can we further lower the smoking rate is a huge problem in medicine and in cancer control. It's a tax issue. It's a mental health issue. It's an agricultural issue. It's a tax issue because I can tell you if we raise the price of excise taxes on cigarettes, we lower the smoking rate, especially lower the smoking rate among teenagers. By the way, there are very few adult smokers who started smoking after the age of 17. Most indeed start smoking when they're 15 or 16. You make cigarettes very expensive, especially for teenagers. They don't smoke. It's a mental health issue because when you look at today's smokers, a large proportion of them have mental health problems. A large number of our patients who have schizophrenia, depression, and bipolar disorder are also cigarette smokers. And it's an agricultural issue because people make a living growing cigarette tobacco, and we need to find alternative things for them to make a living in so they won't make tobacco or grow tobacco. Now, cervical cancer is a very interesting disease. As I said earlier, it was the most common cause of cancer death for women in the 1920s and 1930s. It affects a large number of women in their age 30 to 50. It was linked to sexual activity very early on. It was noted that nuns never got it unless they were bad girls before they became nuns. It was noted that it was very common in the wives of men the second wives of men whose first wives died of cervical cancer. For a long time, it was thought to be a sexually transmitted disease, and there was a search for an agent. Today, the death rates are dramatically lower in most Western countries, although it's still the leading cause of death among women in South America and Africa. And it is the second leading cause of cancer death among women worldwide. This gentleman, George Papanicolaou, in the 1920s and 30s perfected cervical cytology, and George Papanicolaou is the inventor of the Pap Smear, which nobody can say except for me, which is why it's called the Pap Smear. This is cervical cytology that you can see over here. It is a way of looking again at stained cells smeared on a glass slide under a microscope and figuring out if the cells are dysplastic, which is precancerous, or actually cancerous, and it's a method of early detection. And the Pap test, which became popular in the United States in the 1940s and 50s and elsewhere later on, is a major reason why we have huge declines in cervical cancer death rates. Harald Zerhausen is a German molecular biologist and virologist, and Dr. Zerhausen actually is the person who figured out that cervical cancer is caused by a virus, the human papillomavirus, or HPV. Indeed, there are a number of different types of human papillomavirus. Papillomavirus 16 and 18 are the most common causes of cervical cancer. He showed that in 1983. Several other types have been identified now as causes of cervical cancer as well. Many HPV viruses cause warts. People have warts on their hand or on their face. Some, unfortunately, cause dysplasia. And HPV, human papillomavirus, is a DNA virus. And DNA viruses are generally vaccinable. You can make a vaccine against it. And indeed, today, we have several human papillomaviruses. Gardasil 9 is the most common. It includes type 16, 18, 6, 11, 16, 18, 31, 33, 45, 52, and 58. And it is safe, prevents dysplasia, which we've used as a surrogate for preventing cervical cancer. It does, since it prevents people from getting precancer, we assume it prevents them from actually getting cancer. The vaccine is widely available. Only a little more than a third of women in the United States have gotten it, which is unfortunately. I travel a lot. In Rwanda, 90% of women aged 9 to 12 have been vaccinated. 35% in the US, but 90% in Rwanda. We are now starting to vaccinate boys. It prevents a number of cancers, and that's the reason to vaccinate boys and girls. But there's also a herd effect that if you vaccinate boys, you can prevent girls from getting the vaccine. As a matter of fact, if you think about it, if I was czar of the world and I could only vaccinate boys or girls, I would vaccinate all the boys because girls don't catch HPV from girls. Today, we know that HPV causes 6 cancers. Cancers of the cervix, the vulva, vagina, penis, anus, and the head and neck. In the head and neck, it causes cancer of the oral pharynx and tonsil. Most people know where the tonsils are. The oral pharynx is where, when the doctor says, say ah, and looks at your mouth, he's looking at or she is looking at the oral pharynx in the back of your throat. It's the thing right back in the very back of the throat. That's the oral pharynx, and that's where HPV can infect and cause a head and neck cancer. That and the tonsils, which are, of course, right in the sides here. A brief history of breast cancer. This is William Stewart Halstead. He was the first surgeon-in-chief at the Johns Hopkins Medical School in Baltimore. And in the 1880s and 1890s, he did a bunch of breast surgery, and in 1895, he actually developed what was called the Halstead mastectomy, which is the way that we remove breasts well into the 1970s for breast cancer in the United States and Europe. These two gentlemen, Bernie Fisher from the University of Pittsburgh and Umberto Viernese from the European Institute of Oncology in Milan, they refined the Halstead mastectomy and showed that you could just remove part of the breast where the tumor is and then radiate it. In my Forrest Gump life, I was fortunate enough to know Umberto Viernese, who's now gone, and I still know Bernie Fisher, who's about 90 years old. They did a series of very elegant clinical trials, starting with the simple mastectomy in 1970 and then lumpectomy and radiation in the 1980s. And then they did studies to show that if we gave chemotherapy after surgery and radiation, we could actually cure even more women of breast cancer. Now, this is a mammogram. Mammogram is an x-ray of the breast. This is the nipple of the breast, and you can see the contour of the breast. And breast cancers show up as white in mammograms. This is a breast of a relatively older woman, somebody who's in their probably 60s or 70s. I can actually age the breast because if I do a mammogram on a 20-year-old woman, the breast is white. If I do a mammogram on a 70-year-old woman, the breast is black. The tumor is always white. And the aging of the female breast from age 20 to age 70 has been described as 50 shades of gray. As it goes from black, as it goes from white to black. You hear a lot of controversy about should we screen women in their 40s or not. The issues are the following. Breast cancer does occur among women in their 40s, but it's much less common than it is among women in their 50s or women in their 60s, number one. And when I'm looking at a mammogram of a 40-year-old woman, I am still looking for something that is white on very light gray, almost white. And when I'm looking for something in a 50-year or 60-year-old woman, I'm looking for something white on a darker gray. That's actually more likely to be there because breast cancer is more common in older women. And so the issue, unfortunately, I wish we talked more about how we need a better test for women in their 40s, but people end up lapsing into should we start screening at 40 or 50 and not the fact that we need a better test. This fellow, Sam Shapiro, who was an epidemiologist again, in 1962 started the first mammography clinical trial. And Dr. Shapiro's trial, the health insurance plan study of New York in the early 1960s showed that mammography screening lowers risk of death by about 20%. He actually showed that it lowers risk of women much better in their 50s than in their 40s, and that it was harder to pick up the tumors in their 40s, and that's when the debate really started. And we still have these debates about starting at 40, 45, or 50, whether we should do it every year, every 2 years. Quality of the image and quality of the radiologist is also a huge issue for me as a medical specialist, although we don't hear about that in the lay press. I showed you the decline in death rate over the 20th century for all cancers. This is for breast cancer. In 1970s, for every 100,000 women, there are about 32 or 33 who died of breast cancer. And we've had this huge decline throughout the 1990s and beyond to today. It's really somewhere around 21, 22 deaths for every 100,000 versus 32. And that's about 35% decrease in risk of death, 35% decrease in mortality. Both statements are true, and you can use them interchangeably. And it's generally a good thing. We're doing better in breast cancer. That's the glass half full way of looking at it, or 1/3 full way of looking at it. But some of us look at it, there's still a bunch of women who die from this disease, and we need to do better. Speaking of doing better, and this is something I mentioned to some of the students earlier today, while we've had a 35% decline in breast cancer death rate in the United States, not in these states. These are the states in orange where the death decline is less than 10%. Why is it a woman who lives in Louisiana, Mississippi, or Alabama is far more likely to die from breast cancer than a woman who lives in Michigan or Minnesota or Massachusetts? That's a huge issue for policymakers. It's actually because treatment for breast cancer, screening for breast cancer, and some of the preventative aspects of breast cancer are not as good in those states. And by the way, these are also the states that have the lowest high school graduation rates. This is the same death rate for black women in blue and white women in red from the 1970s beyond. And this is just to show you there were no black-white disparities using that socio-political categorization. There were no black-white disparities in the 1970s, but today the disparities are greater. Not saying that black versus white doesn't matter. I'm saying that black versus white is not biological. This is a socio-economic phenomenon that we have a huge disparity in death rate for black women versus white women. And in epidemiology, we've actually been able to show that if you're black, if you're an American woman with breast cancer, there's an 80% chance that you'll get good care. 20% of white women get lousy care for breast cancer, and I just showed you what states they live in for the most part. Well, black women in the United States are 2/3 as likely to get good care as white women. And then, of course, we have the prevention aspects. Quality of screening, quality of treatment, all of these things are all different, and we need to focus on. In colorectal cancer, we've got great studies that tell us that stool blood testing, sorry to talk about that before lunch, saves lives. Sigmoidoscopy saves lives. Colonoscopy saves lives. Ironically, the studies that tell us that stool blood testing saves lives are stronger than the studies that tell us that colonoscopy saves lives. Those of you who've read my book, that's because people can charge $2,000 to do a colonoscopy, and you only get to charge $30 to do stool blood testing. That's why colonoscopy is more common in the U.S. This is something that we actually developed, our epidemiologists at the ACS developed this as a support for why we need universal health care in the United States. This was actually used in the arguments for the Affordable Care Act, which is now called Obamacare. This is 5-year survival rates, and how you read this is stage 1 or low stage colon cancer is in red, stage 2, which is a little bit more advanced, is in blue. The insured are solid lines, the uninsured are dotted lines. This decline over 5 years, 60 months in the x-axis, this decline means 90% are alive at 5 years. 90% of your stage 1 insured are alive at 5 years. This dotted line means that 80% of your uninsured, 80% of your uninsured stage 1 are alive at 5 years. So among stage 1, being insured improves your chances of survival by about 10%. And similar here for stage 2. It's a worse disease, so insured does better than uninsured. And the thing that was the newsworthy here is, in the United States, you are better off having a more advanced stage 2 colon cancer with insurance than having the less advanced stage 1 colon cancer without insurance. You're more likely to be alive at 5 years if you have the worst disease and you have insurance. Keeping with my Massachusetts versus Mississippi analogy, this is work that's done by some of the folks who work with me at the American Cancer Society. This is the decline in death rate in Massachusetts and New York over the last 20 years or so compared to the declines in Alabama and the lack of decline in Mississippi. We used to talk about disparities black-white, then we started talking about disparities rich-poor, and now we're talking about disparities Massachusetts versus Mississippi. This is racial disparities. In the 1970s, for black men and white men, there were essentially no disparities. Actually, the disparity, if it existed, was for white guys. For black women and white women, again, no disparities in the 1970s. Since we learned how to treat and prevent colorectal cancer, the disparities have grown. And the difference for black men and white men and for black women and white women are greater today than they've ever been. The disparities are increasing as we learn how to screen, prevent, and treat these diseases. Again, quality of screening, quality of care, quality of prevention are all important. Now, in epidemiology and cancer control, we've also been looking at what are the causes of cancer. Told you about smoking. We've done large cohort studies following 400,000 people over time, looking at risk factors, asking them what they eat, what they do for a living, so forth, seeing what happens to them over time. And we found that the combination of obesity, poor nutrition, which is too many calories, and physical inactivity is the second leading cause of cancer. It's the second leading risk factor for cancer. It's a three-legged stool. It's not obesity, it's obesity, too many calories, and not enough physical inactivity. We were talking earlier today, Michael Phelps, when he's in training, consumes 12,000 calories a day. He can do that because he burns that off, and he's not obese. He has an incredible low body fat. Then the next cause of cancer that I want to talk about are viruses, and we mentioned HPV already, but infections are a leading cause of cancer around the world. Not as much in the United States except for HPV, although H. pylori, which is a stomach infection, causes some gastric cancers and some lymphoma in the United States. Hepatitis B and hepatitis C, especially hepatitis C, are huge problems in the United States. Hepatitis B is vaccinable. Most of you guys at your age have actually been vaccinated against hepatitis B. For my generation, only people who are healthcare providers have generally been vaccinated. Hepatitis C is growing in commonality in the United States. And that's an important virus because it causes liver cancer, but it's also treatable. We have drugs that can cure about 3/4 to 85% of people with hepatitis C. Unfortunately, the cure for hepatitis C costs $50,000 to $75,000. HIV, or the human immunodeficiency virus, causes lymphoma, a number of other cancers. Human herpes virus 8 causes some cancers. Epstein-Barr virus, we talked about HPV. Schistosomiasis is only a real problem. It causes bladder cancer among people who live along the Nile. Merkel cell polyoma virus is also a problem. So again, I've talked about obesity, lack of physical activity, and poor diet. It actually causes diabetes, cardiovascular disease, as well as orthopedic disease and cancer. It causes all the major chronic diseases. Cardiovascular disease is heart disease and stroke, by the way. And orthopedic disease is the need for hip replacements and knee replacements. This is a slide that I promised somebody in the last talk I was going to insert. This is obesity in the United States, body mass index greater than 30. This is, and yes, the fat guy's going to talk to you guys about obesity. This is a body mass index of 30. 15% of Americans in 1970, about 35% of Americans in 2010. Look at England, Canada, Spain, France, Switzerland, Korea, even Italy, much lower than us. We need to look at the built environment, the things, our normal ways of life that actually cause us to actually gain weight. The fact that we consume too many calories, we can get calories cheaply here. I mentioned earlier today, in 1960 there were 6 McDonald's restaurants in the United States. Today they're probably opening 6 every week around the world. But anyway, these are obesity figures for certain races and ethnicities in the United States, and this is something we desperately need to work on and actually can save an awful lot of lives. The National Cancer Act, this is Richard Nixon. For those of you who were born this century, he was a president of the United States. He signed the National Cancer Act. Ted Kennedy, for those of you born this century, he was a senator. He was the brother of another president. He called this Richard Nixon declaring war on cancer. This is in 1971. The National Cancer Act put a lot of money into cancer research, put a lot of money into the kinds of things that I do, the kinds of things that are done here at U of D, or U of D Mercy. I'm getting there. When I grew up, it was U of D. It wasn't U of D, it was U of D, okay? And so we're learning about genotyping, we're learning about genetic sequencing, bioinformatics, a number of different things. It all stems from that investment that started in 1971 with the National Cancer Act. With that National Cancer Act knowledge, we are moving from the definition that Virchow gave us in 1853 of cancer that just involved the biopsy to a 21st century definition as we move into what's called precision medicine, targeted immunotherapies. This is again a biopsy of an adenocarcinoma, this time of the lung. And this is what we would say this poor person has lung cancer just 15 years ago. Today, we not only say this is lung cancer, but we start looking at what genes are messed up in it. What genes are mutated in it? Is there a MEK gene, a MET gene, a HER2 gene, a BRAF gene that's mutated? And in some instances, for example, if we have an ALK gene mutation, I have very specific drugs to treat that lung cancer. Actually, ALK is the real great example because we have people who have metastatic lung cancer with an ALK mutation, something that in the year 2005 had a 1-year survival at best. We have people who are now alive 8 to 10 years who are taking crizotinib, which interferes with the mutated ALK gene. And similarly for other genes, the BRAF gene, we have very specific drugs. And so things are looking better. On the immunotherapy front, we're actually starting to train people's T cells to actually attack the cancer and in many ways reject the cancer as if it were foreign, the same as the immune system would want to reject a kidney or a heart or a liver that I transplant into the patient. Interestingly, when we transplant an organ into the patient, we try to stop the immune system from attacking those things and rejecting it. In the cancer patient, I've now got drugs to actually make the immune system try to reject the cancer. And some of these things are actually working. And so, little review of what cancer control is, looking at cancer in the population. And I want you to leave here thinking, we have made some progress. We could have made greater progress. I want you to think about people in Mississippi. We can still make significant progress, although there's been huge incomplete application of what we know. And some of the things that we know involve smoking, involve diet, involve exercise. And somebody asked a very important question earlier today, what can we do? And the answer to that, what can we do, is we can try to get everybody, including ourselves, to be healthy. And so I'm going to say thank you. It's been a lot of fun to be here and to be with you young guys. Do we have time for questions?
We do.
Fern?
I heard, well, I read somewhere that the World War I soldiers were introduced to cigarettes.
Yes.
And then I also heard that the smoking rates among white teenagers is much higher than the smoking rates among black teenagers, maybe because they can afford them. But also for the rebuild students, the last time you were here, I was wondering if it'd be interesting to see if they read the Immortal Life of Henrietta Lacks, which is very good for those who read.
Yes.
And the other question, finally, the most important question, we can see it from the NIH, and rebuild was written by Wayne State under the direction of M. Roy Wilson, Dr. M. Roy Wilson from the NIH. Well, I had Dr. Mona Tasha. She's up in Flint. I know you've heard about the watercraft honor, and she's Kathy and Catholic physician, pediatrician, master of public health. But if it would be possible to hook up with Roy Wilson, Dr. Mohan Akasha, and possibly write Rebuild Flint. There's a lot going on up there. I know they're stretching.
Sure, sure,
I'll be on you.
sure. Okay, yeah, Roy Wilson's a wonderful man. He's the president of Wayne State University and a personal friend. First, cigarettes were part of the rations. When men fighting in World War I were given food, they were given a pack of usually 4 cigarettes, I believe. And that continued in World War II, and actually smoking rates went up dramatically in World War II. It happened in World War I, but it happened in World War II as well, and it was actually worse. In terms of teenage smoking in the African American population the numbers are better than they are in the Caucasian or white population right now among teenage smoking. And we follow teenage smoking because, as I said earlier, very few adults started smoking as adults. They usually start smoking at the age of 15 or 16. I will talk to Dr. Wilson. Now, the NIH issues requests for applications, and the rules can be very strict. I don't know if the NIH has offered anything that a Rebuild Flint could apply to. Okay. Yeah. Okay. Next, yes, sir.
You mentioned you mentioned the mastectomy and how we're currently treating, and maybe how we're moving to. I was curious to know if you or the American Cancer Society has moved towards maybe monitorization rather than maybe the mastectomies. So like during the initial, maybe you mentioned at like 20 years old, when you noticed that scan showing kind of a whitish or like you said, the grayish with the white around, would the American Cancer Society maybe recommend to monitor that and see if there's any changes or like where are we going with it?
Well, first off, the American Cancer Society doesn't make any treatment recommendations. We actually do make recommendations regarding cancer screening. If someone has a mass like the one that I showed there, what we do now, and the common practice of medicine, indeed, it would be inappropriate for a doctor to do otherwise. The practice would be to biopsy that. And if that biopsy shows that it is ductal carcinoma in situ, which is a precancerous condition, there are some clinical trials that a woman can go into where her lesion might be watched versus immediately treated. And the treatment for a ductal carcinoma in situ that's preferred is to remove the lump, not the entire breast, but the lump, and radiate it. If that biopsy were true invasive cancer, frank, real cancer, currently everybody should be advocating that the woman get either a mastectomy, which is just removal of the breast, not the old Halsted mastectomy, which was really the removal of the chest wall and the breast, but removal of the breast, or removal of the lump followed by radiation. And many states actually have instituted laws that say that the doctor must tell the woman it is her choice to get removal of the entire breast or the lumpectomy with radiation. And many states, almost every state that I can think of, have told insurers that if the woman chooses to get mastectomy, then the insurance must pay for a plastic surgeon to do breast reconstruction. Yes, sir.
I was wondering if you could comment with, we have some younger students here, obviously. My previous position, I was in the Middle East, and there's a much higher percentage of males and females that smoke where I was. And quite a few of them, through some encouraging were actually to quit smoking via vaping.
Ah,
And I know that's kind of a hot button issue. It seems like
Yeah.
it's all over the place.
Yeah.
Particularly honest. I personally saw it more like, well, you're stopping smoking, so that's a better, if you're smoking,
Yeah.
water
Yeah.
vapor. But obviously, I'm not a
Yeah.
professional like
Okay.
yourself.
yeah. Vaping, electronic cigarettes didn't exist 12 years ago, surprisingly. Vaping is a way of nebulizing or putting into a mist various chemicals. And the various is the key operative word here. Some of the vaping formulas, we don't know what's in them. We know some of the vaping has nicotine in it. Some of the vaping has various flavorings and other things. I know that we've analyzed tobacco smoke, and tobacco smoke has at least 60 chemicals in it, which if you take those chemicals and inject them in laboratory animals, you will cause a goodly number of the laboratory animals to develop cancer. So we know that tobacco smoke has at least 60 different carcinogens in them. Marijuana, by the way, has 30 some odd of those 60 in it. Vaping, the vaping companies have not really told us what's in the vaping formulas. So we have no idea what people are inhaling. There are some of my friends who study this who actually worry that vaping is going to cause a lot of pulmonary fibrosis, which is another lung disease that is problematic. I am willing to say on the record, and this is actually American Cancer Society policy, that we do believe that vaping is safer than combustible cigarettes, but there's a difference between saying that something is safer and saying that it is safe. Also, there are some data that I have to acknowledge that vaping may be a way for some people who use combustible cigarettes to get off of combustible cigarettes, and there may be some redeeming social qualities in e-cigarettes in that one might be able to, who's addicted to tobacco, and keep in mind, nicotine is more addictive than cocaine. It is hard for someone who smokes combustible cigarettes to stop. That's why I stress don't start. It might be that e-cigarettes can be used to help someone to wean off of combustibles, and then if they can wean off of the e-cigarettes, that would be wonderful. But there are anecdotal examples of that. There's no real studies. And the last thing I will tell you is the e-cigarette companies in the last 5 or 6 years have all been bought up by the tobacco companies. And the tobacco companies are not willing to disclose what's in the e-cigarette nebulizer stuff. They're not willing to do any studies to show that this is good to help get off of combustibles. And so, there's rotten fish that I smell there.
Right. Is there, sorry.
No, this is important. This is.
Like I said, I've noticed that it's becoming more and more of a trend, and
It is.
it helped a lot of my former students really quit. But I guess my question is there a better or more open brand versus that you can tell?
I can't tell you there's a better or more open brand. I wish there were.
Yeah.
I wish there were. Yeah. No, but this is the hot button issue right now is e-cigarettes. Somebody back there. Yes, ma'am, in pink.
Can you address secondhand smoke?
Oh, yeah.
There is both smoke in the house.
Oh yeah, the worst is when the car.
Yeah, in the car.
Yeah. Yeah.
Air conditioning.
Yeah.
windows.
Yeah. Secondhand smoke causes a lot of things. It causes crib death. It causes COPD, chronic obstructive pulmonary disease. It increases the cardiac death rate. As a matter of fact, there are a number of cities that actually said no more smoking in bars and restaurants, and 6 months after they implemented that, the heart attack rates went down. Okay? Cigarette smoking causes lung cancer, and unfortunately, I see a lot of people, 80% of lung cancers are caused by cigarette smoking, and some of the 80% are actually people who were exposed to parent cigarettes when they were 5 and 6 and 7 years old, and they're now 60 years old and they have lung cancer. Yes, sir? Yeah. 80% of all lung cancer is caused by cigarette smoking. Some of that 80% are people who never smoked themselves but inhaled secondhand smoke, and some of that secondhand smoke was from their parents when the 60-year-old was less than 18 years old. Yes, sir?
Maybe ask you to just step out of your professional role here for a second, but would it be wrong to argue that cancer receives significantly more funding and publicity from government and non-governmental agencies compared to, say, diabetes, hypertension, or cardiovascular disease?
Cardiovascular disease, no. Diabetes, maybe. Sometimes the money that's spent has some commonality. You know, for example, these huge cohort studies that we've done in cancer are the ones that actually showed that obesity causes cancer and cardiovascular disease and diabetes. So sometimes there's some overlap. I'm a big proponent of funding the science that's most easily answered, and we can get into a great conversation about the disease Olympics within cancer. You know, you have all the folks who want money to go into pediatric cancer, all the folks who want money to go into breast cancer. You actually have a prostate cancer group that actually decided to call itself Us Too, directly in relationship to the fact that they felt that prostate cancer wasn't getting money. And the reason why I like to fund the most answerable question is I mentioned crizotinib, which is making some of these lung cancer patients live nowadays, this new drug. It's not new now, it's 10 years old. Crizotinib hits the ALK gene. The ALK gene is the acute leukemia kinase gene. It was discovered in the mid-1990s by people who thought they were doing leukemia research. Then some folks who thought they were doing thyroid cancer research, who actually read the whole literature and are very well read and well versed on things other than thyroid, they discovered that the ALK gene was in thyroid cancer. And they're the ones who actually found this chemical and figured out that this chemical interrupted the mutated product of the ALK gene, this chemical crizotinib. And then there were some guys and gals who did lung cancer research who came up with the brilliant, oh, there's the ALK gene in lung cancer too. What if we try that chemical that the thyroid cancer people gave us? And that's how we got crizotinib in lung cancer. So, and I've actually seen a lung cancer advocate stand up and talk about screw thyroid cancer, screw breast cancer, screw prostate cancer, put all the money in lung cancer research. And he doesn't realize if we had screwed thyroid cancer research and lymphoma research, leukemia research, he wouldn't be alive because he's one of the first people to ever get crizotinib. So there are lots of crossover, especially in the diabetes and especially in the cardiovascular disease. The whole area of inflammation, inflammation causing coronary plaque, inflammation causing cancer, lots of crossover there. And so I'm into funding science. And I would point out that I'm much more versed at talking about cancer diseases. The cancer that gets the most money from the NIH right now is breast cancer. They got $600 million last year. Okay? The Department of Defense budget for bands and music is $650 million. This country spent more money on John Philip Sousa last year than it spent on breast cancer research. Yes, ma'am.
Recently, I saw a documentary that was called What the Health, and they were talking about processed meat.
Yes.
Carcinogens. Can you elaborate on that?
Yeah. There's a bunch of garbage things out there. Yeah, I'm a big guy. I can actually take a hit, so I'll throw something on. That one has been especially painful because it sounds, it's got a couple of stars in there, and that immediately gives it a lot of credibility and that sort of stuff. The basic rule of thumb, I love these guys who do these things about how processed meat causes cancer, and then they go out and they smoke their marijuana. The basic rule of thumb is everything in moderation. Yes, char and charbroil is a carcinogen. Yes, processed meat like bologna and hot dogs are weak carcinogens. The problem in the United States is not that people eat hot dogs and get cancer. The problem is people eat too many hot dogs. And I'm really into calorie control and diversity. The one thing I would tell people is do eat 5 to 9 servings of fruits and vegetables per day. One serving is a medium-sized apple or a tangerine or something like that, or half a cup of broccoli. Do try to eat 5 to 9 servings of fruits and vegetables. If you want to be a vegetarian, that's fine. There's nothing wrong with being a vegetarian, but don't give up meat because you think it's going to gain you something that we just scientifically haven't proven.
And leading on from what you said in terms of moderation, so what relationship when it comes to tobacco and versus nicotine, basically under the umbrella of moderation, are you talking about tobacco and heavy smokers?
Oh, I'm actually saying don't smoke at all. Cigarettes are the only thing I know of that when manufactured and used as the manufacturer intends, kills 2 out of 3 people who use it. And there's no safe level of cigarette smoking at all. Now that being said, people who smoke more cigarettes are more likely to get a lot of these diseases than people who smoke less, but people who smoke less are not without risk. Yes, ma'am.
I think we can do one more, but I did want to mention, since there are a lot of hands up and a lot of good questions, that Dr. Brawley is going to be having an open discussion in chemistry 114 and 130. So I think we have time for one more question now, but please come to that, bring your questions, and we'll keep asking as long as he's willing to keep answering.
Yeah.
Okay, given the fact that you said half the carcinogens that are found in tobacco are also found inside of marijuana, do you believe that the legalization of marijuana in the United States should be carried on?
Do I believe in the legalization of marijuana? Yeah. My answer about marijuana is very similar to my answer about tobacco in terms of recreational use. I see no reason for it. That being said, there are chemicals in marijuana that clearly have medicinal use. We are so stuck up on marijuana in the United States that we have made it very, very difficult to do any of the research to find those chemicals and categorize them, figure out what their uses are and what their doses are. We've done it in some respects. There's a drug called Marinol, which any doc who has a DEA license can write for nausea and vomiting. Marinol, as the name implies, is THC from marijuana. Okay? Now, If I have a patient who's getting chemotherapy, I can write them a Marinol prescription, and I can know exactly what dose of Marinol they're getting. I know it's pharmaceutical grade. I know its purity. I know how often they're getting it if they're taking it every 4 hours, as I say take it. Okay? If I give them, I wouldn't give them, but if they start smoking joints, I don't know how much THC they're getting, because marijuana varies by the quality of the THC that's in it, and as well as I know that they're getting all of those other things that can cause not just cancer, but cause chronic obstructive pulmonary disease and so forth. I do believe that some people who smoke marijuana because they have multiple sclerosis, because they have nausea, because they have various fear, what am I trying to say? Anxiety problems. I do believe that those people do get some help from smoking that marijuana. I just wish that this country would support the research so that we can turn those leads into drugs that I can use, and use them in a much more reasonable, effective way to try to benefit those people. I didn't give you the answer you were expecting, did I? All right. Thank you so much.